بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll continue the topic of skeletal fractures, and we are still discussing the fractures of the upper limb. And we have finished with the phalangeal fractures, then the fractures of the carpal bones, and we finished by um, the fracture of the hook of Hamid. Then we are going to discuss fractures of the forearm bones, to be followed by elbow joint lesions, then the fractures of the humerus, and we finish by the lesions at the shoulder level. And we have discussed before that there are two main types of incomplete fractures that occur in children. These fractures are commonly seen in the forearm bones, and they include the uh, green stick fracture and the torus or the buckle fracture. Then remember that these fractures usually the result of axial load, and this will initiate some sort of trabecular injury, and actually you may see some buckling of the cortex, and sometimes you can also see a fracture line if the buccal fracture is associated with the green stick fracture. And you remember that the Salter-Harris types of fractures are also seen in the immature skeleton, and they have a, a reference to the physial blade if it is involved, or the fracture is above, or the fracture is below. Then the green stick fracture means that there is disruption of one side of the cortex while the opposite cortical bone is intact, exactly similar to the green stick of any tree. Then the torus fracture is known as buccal fracture, and this is a fracture which results from an axial load initiating some sort of trabecular injury with cortical buckling, as you can see here. If the traumatic force is in the form of an oblique one together with an axial overload, this will result in buckling on one side of the bone while the other side looks to be intact. And this is a good example of a torus or buccal fracture of the distal part of the radius, where you can see the hair fracture line with buckling of the medial cortex of the radius. Then we came to one of the famous fractures in the wrist, which is the Colles fracture. And this Colles fracture is common in elderly patients, especially women. It involves the distal radius with volar apex angulation and dorsal displacement of the distal fragment, exactly similar to a fork. The cause in most of the cases is fall on the outstretched hand with extended wrist and a pronated forearm. In about 50% of these Colles fractures, the ulnar styloid process is also fractured. And you see here, this is a fracture of the distal radius and the dorsal displacement of the dorsal fracture segment. as I have mentioned, is commonly seen in elderly patients, especially those with osteoporotic, particularly in women. This fracture includes three main classic deformities. Number one, dorsal displacement of the distal fragment. The distal radial fragment is displaced dorsally. Apex volar angulation, and you see this angle on the volar aspect of the hand. Then radial shortening, because these fractures are frequently impacted. One of the types of fractures related to Cooley's is what's known as die punch injury, which is an extensively comminuted fracture involving the distal part of the radius with proximal displacement of the lunate and maybe the scaphoid bone. And this is an example of Cooley's fracture in the distal part of the radius with dorsal displacement of the distal fragment and the volar angulation, which is one of the classic deformities of Cooley's fracture. And Smith's fracture is similar to Cooley's fracture, um, especially at the site of the fracture, which involves the distal radius, but the displacement is opposite to that seen in Cooley's fracture. The distal fragment in Cooley's fracture is displaced dorsally, while in Smith fracture, the distal fragment is displaced volary, and the apex angulation is usually on the dorsal aspect. And it is clearly stated in the literature that Cooley's fracture is far, far common when compared to the Smith fracture. Then we have two well-known fractures affecting the forearm bones, the Galeazzi fracture and the Monteggia one. Galeazzi fracture involves the radius and the distal radioulnar joint. The radial shaft is fractured and the distal radioulnar joint is dislocated. And this is a good example. You see the radius, there is a fracture with overlapping edge with disruption of the distal radioulnar joint. You see the ulna is far away from the radius. This is also another example of Galeazzi fracture with involvement of the radial shaft and the disruption of the distal radioulnar joint. Then you came to the Monteggia fracture, and you can remember the two types of fractures because sometimes uh, you may do some mistakes between both. And you know that Monteggia, there is N in the name of the fracture, and there is N in the bone involved. Monteggia fracture involves the ulna with dislocation of the radial head, the proximal radioulnar joint. And commonly, the radial head is displaced anteriorly, but there are many sub-classifications of this Monteggia fracture according to the direction of the radial head displacement. This Badu classification entails that the original Monteggia fracture involving the ulna with anterior displacement of the radial head. Then if the radial head is displaced posteriorly, then this is type 2. If the radial head is displaced laterally, then this is type 3. If the radial head is displaced anteriorly and the radius is fractured as well, this means that there are fracture of both forearm bones with radial head displacement anteriorly, and this is type 4. And this is classic type 1 Monteggia fracture. The ulna is involved and the radial head is displaced anteriorly. And this is type 3 Montague fracture with involvement of the ulna and the lateral displacement of the radial head. In fractures of the forearm bones, the green stick fracture, which may involve the one of the forearm bones, and they may have one of three types: the transverse fracture halfway across the bone, a classic green stick one; bowing fracture, the bone is bent with no distinct cortical disruption, and you can consider this as a fracture type, which is also seen in the zygomatic arch. In torus or buckling fracture, the cortex is buckled and overlapped, caused by trabecular injury and impaction. Then, in children, the fractures are treated by closed reduction and cast fixation, and then the fracture will heal in about 6 to 8 weeks. In adults, the operative treatment is usually indicated, and the fracture is internally fixed by blades. Then we came to the radial head fractures, which is one of the common intra-articular injuries at the level of the elbow joint. This is one of the common fractures in adults and is considered the most common cause of elbow joint effusion in adults, while the most common cause of elbow joint effusion in children is the supracondylar fracture. And this is a very good sign, which is known as the fat pad sign for the detection of elbow joint effusion. This fat, I will show it in a moment, is very important whenever you see the fat pad sign indicating that there is a joint effusion after trauma. Then you should consider a radial head fracture and look very carefully to the radial head, searching for this fracture. In this video, I hope it works, so you can have an idea about this fat pad sign.
Hi, I'm Dr. Andrew Dixon from Radiopedia.org, and in this tutorial we're going to learn how to recognise an elbow joint effusion on a lateral radiograph. This is an important clinical skill, particularly in the setting of trauma, where a joint effusion is almost always an indication of an elbow fracture. So we're going to start with a little pre-test. Different patients, some of which have effusions and some of which do not. Have a look yourself and try and work out where the effusions are. If you're not already, then I recommend watching this video in high resolution, as diagnosing an elbow joint effusion requires subtle detection of the elbow fat pads. So let's begin by looking at the elbow fat pads, which normally sit adjacent to the distal humerus, from which they are separated only by a thin reflection of joint capsule. The anterior fat pad fills the shallow coronoid fossa, while the posterior fat pad sits within a much deeper olecranon fossa. Here's a lateral radiograph of a patient who has chronic gout affecting their olecranon bursa, but who does not have an elbow joint effusion. You can see here the normal orientation of the anterior fat pad, which is detectable just in front of and paralleling the distal humerus. It is visible as a darkened area because the fat is considerably lower density than the adjacent musculature. As is normal, the posterior fat pad is not seen, as it is hidden within the olecranon fossa. These T1 weighted MRI images in a patient without a joint effusion demonstrate nicely why the posterior fat pad remains hidden by bony structures on a lateral image, while the anterior fat pad sits visible. Here's an example of a normal child's elbow, which also demonstrates the expected appearance of the anterior fat pad and an undetectable posterior fat pad. Let's now have a look at what happens to the fat pads in the presence of a joint effusion, which we have coloured red in this diagram to indicate hemarthrosis. As you can see, the effusion expands the capsular recesses and displaces the fat pads away from the humerus. The anterior fat pad is pushed outwards and upwards, while the posterior fat pad is displaced posteriorly. Here's a patient with a radial neck fracture who has a large elbow joint effusion. You cannot see the joint fluid or blood because it is of similar density to muscle, but what you can see is the displacement of the low-density anterior fat pad, which we can draw in here, and from which we can imply that there must be an effusion. We can also see the posterior fat pad protrudes behind the posterior margin of the humerus, known as the posterior fat pad sign, implying abnormal distension of the posterior joint recess, which we can draw here. And for further correlation, here is a CT image confirming how the low-density fat pads are displaced by an effusion. The triangular appearance of the displaced anterior fat pad has been likened to that of a sail, and for this reason it is often referred to as the sail sign of elbow joint effusion. So let's return now to our 6 cases and see how many effusions we can find. A, B and D are all adults with joint effusions, each demonstrating sail signs and posterior fat pad signs. B is the patient we have already seen with the radial neck fracture, while A and D have subtle radial head fractures, which are the most common cause of an elbow joint effusion in adults. F is our friend with chronic gout who does not have an elbow joint effusion, while C and E are pediatric patients, with C being the normal example without a joint effusion, and E being a patient with an elbow joint effusion related to a supracondylar fracture, which is the most common cause of an elbow joint effusion in children. So hopefully now you'll be able to confidently identify elbow joint effusions on lateral radiographs by looking for the sail sign and the posterior fat pad sign. You can read more and see other case examples on radiopedia.org.
Danny, I hope that you can understand now the idea of the fat pad sign. Then we'll continue the moment. Yeah, we have mentioned that the radial head fractures are common in adults, and they are considered the commonest cause of elbow joint effusion, and the joint effusion is identified by detection of the fat pad sign. And considering that this fracture is an intra-articular one, there should be early active motion of the joint, and open reduction with internal fixation is considered if there is marked displacement and comminution. And the idea of radial head resection alone is not recommended for cases with acute trauma. In here, it's easy to identify the fat pad sign in this patient with radial neck fracture, and you can see this radiolucent triangle along the lower part of the anterior aspect of the humeral shaft, and also the translucent or the radiolucent fat pad sign along the posterior aspect of the humerus as well. And this is a CT scan and showing clearly demonstrating the fat pad sign, which is an indication of the presence of joint effusion. And also MRI is one of the good modalities to see the effusion and to see the fat as well. This is the fat which is bright in the T1 weighted image anteriorly and posteriorly, while this is the effusion which is of low signal in the T1 and high signal in the T2 weighted images. Then we have many types of olecranial fractures, and we will not go through these in details. If you are confronted with an olecranial fracture, simply you mention the fracture site, and you know that most of the olecranial fractures will involve the articular surface. Then they need aggressive way of management, including adequate fixation, early motion, and to prevent the stiffness of the elbow joint. Just you say if the fracture is simple or comminuted. if there is a significant displacement or not. And this is an example of olecranial fracture affecting the olecranial process. It is a simple fracture with no significant displacement, and you can appreciate the presence of elbow joint effusion considering the fat bad sign. And this is also an example of olecranial fracture, which is a little bit comminuted with no significant displacement. And this is a fracture with a considerable displacement of the olecranial process being pulled up by uh, uh, the triceps tendon, as you know. Then we came to the dislocations of the elbow joint, and dislocations usually occur posteriorly with displacement of the olecranial process along the back of the humerus. And this type of injury frequently results in fractures of the radial head as well as fracture of the ulnar process, and this is known as the terrible triad. This terrible triad is the combination of posterior dislocation of the elbow, coronoid process fracture of the ulna, and the radial head or neck fractures. In the elbow joint dislocation is the most common joint to be dislocated in adults after the shoulder joint, and the dislocations are closed, and most frequently they are posterior in the direction. Simple dislocation with no fractures or complex dislocation with fractures, and these are the commonly associated fractures. Of course, the radial head is one of them. And this is the terrible triad of elbow joint dislocation. The ulna is dislocated posteriorly, the coronoid process is fractured, and the radial neck is also fractured. And this is the reported checklist whenever you are confronted by a case of elbow joint dislocation. And you mention the direction of dislocation, which is commonly posterior. Then you mention associated fractures, especially the radial head and the coronoid process of the ulna. Then you assess for other fractures in the lateral condyle, the capitulum, or the olecranium, and don't forget to look for the shoulder joint. Then we came to the supracondylar fractures, which are these fractures usually seen in children, and they are, in most of the cases, they are simple and they are also extra-articular. The distal fracture fragment is usually displaced posteriorly, and 90% of these fractures are seen in the children younger than 10 years with the peak of age between 5 and 7 years. These injuries are almost always due to accidental trauma, and they may be classified as type 1, which where the fracture is undisplaced, type 2, displaced fracture with intact cortex, somewhat like the green stick fracture, and the fracture with complete displacement. One of the helpful signs in the plain X-ray is to do these lines in the lateral X-ray of the elbow, a line which is going through the axis of the radius, and a line which is tangential to the anterior cortex of the humerus. Both lines will intersect the midpoint of the capitulum in normal conditions. Then these are the two lines, a line through the axis of the radius, and the second line is along the anterior cortex of the humerus. Then both lines will meet in the middle third of the capitulum in most of the children. And if there is some malalignment of these lines, then you consider or look carefully for fracture in the supracondylar area of the humerus. Also, a helpful sign is the anterior and posterior fat bed signs. You know that they are present in cases of elbow joint effusion, where the supracondylar fracture is considered the most common fracture to result in elbow joint effusion in the pediatric age group. This is an example of non-displaced supracondylar fracture of the humerus. And of course, if you perform the previously mentioned lines, you cannot see that these lines meet in the middle third of the capitulum. And distal humeral fractures in adults are usually intra-articular, while those in the children, they are extra-articular most commonly. And these intra-articular fractures are difficult to be treated and may result with stiffness and arthritis of the elbow joint. So they need frequently the open reduction with rigid fixation and early immobilization, since if the elbow is immobilized for 3 weeks or more, then you are afraid of stiffness and the pterotopic ossification, meaning that the development of myositis ossificans. One of the important anatomic structures in this area is the ulnar nerve, which should be looked for during surgery to prevent its entrapment. And fractures of the humeral shaft are also common, and displacement is generally due to the effect of the muscles uh, on the fracture segments. Then the radial nerve here may be involved, and you know that the radial nerve has its course within the arm, as explained previously in the elbow joint lecture, and convoluted fractures are treated with internal fixation, while the simple fractures may treated by external fixation. The conservative treatment with external fixation aims at establishment of union with acceptable alignment, and more than 90% of the humeral shafts will heal with non-surgical management. And you remember that these issues, according to the literature, are all acceptable. 20 degrees of anterior angulation, 30 degrees of varus angulation, and up to 3 centimeters of shortening are acceptable when considering these fractures of the humeral shaft. Then proximal humeral fractures, like the fractures of the proximal femur, are commonly seen in elderly patients, especially those who are osteoporotic. This fracture of the proximal humerus is similar to the Coulis fracture, similar to the femoral neck fractures, which are seen in elderly osteoporotic people. Then one of the important issues is to initiate early movement of the joint with proper fixation to prevent the stiffness of the shoulder. These fractures may occur in young adults as a result of high energy trauma or sport injuries, as you know. Many times these fractures are associated with dislocation of the shoulder, or the fractures extend to involve the articular surface, which will present a significant problem if it involves the articular surface. Then proximal humeral fractures may be classified into extra-articular fractures, which do not involve the articular surface of the humerus, and These fractures may be unifocal, meaning that a single fracture involving the shaft of the humerus, the greater or lesser tuberosity, or multifocal involving the humerus, the greater and the lesser tuberosity. Then one of the ways of classification of these fractures is known as near classification, which deals with the fracture according to the segments. We may say that we have two segment fracture, three segment fracture, and four segment fracture. The segments are the head of the humerus, the shaft, the greater tuberosity, and the lesser tuberosity. The segment is considered if the fragment is separated by 1 centimeter or angulated by more than 40 degrees angle. It is considered a separate segment or a separate part of the fracture. Then you can see multiple examples of intra-articular fractures, like this one involving the greater tuberosity, and this one with impaction of the humeral head against the glenoid rim, and this comminuted fracture partly displaced and partly non-displaced together with dislocation of the shoulder. And here is the extra-articular examples of extra-articular unifocal fractures. One segment affecting the greater tuberosity, the humeral shaft, whether it is non-displaced or displaced. And this is extra-articular multifocal fracture with involvement of the greater tuberosity and involvement of the humeral shaft. Then we came to the injuries of the shoulder, and then we have three main lesions here: lesions of the clavicle, lesions of the acromioclavicular joint, and the involvement of the shoulder joint itself. Clavicular fractures are classified into three types. The most common type is that one involving the middle third of the clavicle, less common the lateral third, and least common affecting the medial third. And this is an important note that displays the fractures lateral to the coracoclavicular joint, meaning the coracoclavicular ligament requires internal fixation due to the high rate of non-union fractures in this particular area. And this is the common way to fix the clavicular fractures by external fixation or the figure of 8 bandage. Then the fractures may be simple and may be comminuted. With this important note is the prolonged immobilization or rigid bandage may interfere with the arm circulation. And this is an example of comminuted middle third clavicular fracture. This is an example how this fracture is internally fixed. The types of clavicular fractures include type 1 affecting the middle third, which is the most common, type 2 the distal third, which is less common, and the least common involves the medial third. These are the suspected associations with the clavicular fracture, like brachial plexus injuries, vascular injuries, rib fractures, scapular fractures, and of course the development of pneumothorax due to injury of the apex of the lung. Then we came to the acromioclavicular separation, and this is a ligamentous injury with no bone fractures. The separation is frequently seen in sport injuries sustained in a fall on a point of the shoulder, and this will result in disruption of the ligaments attaching the clavicle to the acromion and to the coracoid, with common displacement of the clavicle upward or superiorly, and less common the clavicle is displaced inferiorly. So we have these types, the 6 types of acromioclavicular separation, and they are nicely presented here. In the type 1, you got just ligamentous injury without displacement, and in type 2, you got disruption of the acromioclavicular joint with minimal displacement, then more evident displacement, and in type 5, the displacement is evident, and then type 6, the clavicle is displaced inferiorly. According to the literature, the type 1 and type 2 injuries are treated conservatively, while type 4, 5, and 6 are treated operatively, and there is some controversy about the management of type 3. For the radiologists, they have to mention only that there is an acromioclavicular separation, and you may mention the distance between the displaced clavicle and its original site against the acromion, and also you look for any associated injuries. Then we came to the glenohumeral dislocations, and we have mentioned some words about this in the lecture of shoulder joint. You know that the shoulder joint is considered the commonest joint to dislocate in the body, followed by the elbow joint. The major or the majority of dislocations of the shoulder joint are towards the anterior aspect. Anterior dislocation of the shoulder represents about 95% of shoulder dislocations, while the posterior dislocation represents about 2 to 4%, and multidirectional dislocation is about 1% of the cases. Then there should be careful examination of the axillary nerve and the radial pulse to be sure that there is no nerve injury or vascular injury. And after reduction of the dislocation, and you repeat the neurologic and vascular examinations to ensure the absence of any injuries. Then about 80 to 90% of the shoulder dislocations are seen in young patients, while 30 to 40% are seen in patients above the age of 50 years. And you remember this very illustrative CT images in the axial and sagittal or coronal reformatted plane. You see the anterior dislocation of the humeral head, which is indented by the sharp edge of the glenoid bone, resulting in this very classic injury, which is known as the Hill-Sachs fracture, commonly associated with anterior shoulder dislocation. And this is the plane films showing that the humeral head is anteriorly dislocated relative to the glenoid fossa, and this is the axillary view showing also the head is anterior to the glenoid fossa. And MRI is the best modality for evaluation of shoulder dislocations, and they frequently see tear in the anterior labrum, which uh, indicates a Bankert lesion. And if you look carefully to the humeral head along its posterior superior aspect, you see an impression or depression, which is corresponding to the Hill-Sachs injury. Finally, anterior inferior dislocation of the humeral head is known as luxatio erecta, and this is one of the rare types of dislocation of the shoulder. And in this type, they see that the humeral head is dislocated inferiorly in relation to the glenoid bone, resulting in abduction of the arm for about 110 to 160 degrees with the elbow flexed, and frequently the arm is on the head of the patient. This inferior dislocation represents less than 1% of the dislocations, and it will result in this erect appearance, the abducted arm and the shoulder, the elbow which is bent with the arm fixed above the head. This injury is usually associated with soft tissue injuries and other bony injuries like labral tears, fractures of the tuberosities of the humerus, axillary nerve injury, which is frequent, and vascular compromise in about 3% of the cases. And this is a good example of inferior dislocation of the shoulder. The head of the humerus is displaced inferiorly relative to the glenoid, and the arm is abducted, severely abducted, and frequently the elbow is flexed. Thank you very much. Alhamdulillah Rabbil Alamin.